one is a case being presented by Dr. Shivam Shah from IKDRC. The second case is being presented by Dr. Amarnath Jha from RN Tagore. So both of these cases are unique in their spectrum. That one is a case where, because of sensitization, a decision to go for desensitization and subsequently for deceased donor transplantation. In another case, a very similar case where again desensitization was the issue. See, the other approach was to go in for a combined ABO incompatible and HLA incompatible cases. So how the teams respectively manage their case. So that is going to be our challenge today. That is going to be the thing that we're going to learn. Let me introduce the experts today. So we have none other than Dr. Pratik Das sir. He's known to everybody. He's the consultant nephrologist, senior consultant nephrologist at the RN Tagore Hospital. Also, we have Dr. Kandaswamy S. He's from Kovai Medical Center, Coimbatore. He has extensive experience of transplant across all borders. His center is a large center for ABO incompatible and a lot of transplants down in the south. And we have Dr. Arpita Ghosh Mitra. She is a transplant immunologist. She has a lab setup of her own. She has vast experience in transplant immunology. Although currently she is working in oncology in the Rajiv Gandhi Center in Delhi, but she has worked in the East and outside of India in the field of immunology. So without wasting further time, I'd like to request the participants to start the presenters to go for the cases. So I think Dr. Shivam Shah is ready with his case. So Dr. Shivam,
Yes,
if you are
sir.
ready, we can please begin.
Yeah, sure, sir. Thank you, sir. So should I start the screen sharing?
Yeah, I think.
Oh,
Sir, it's allowed, sir. You can share the screen, sir.
is it visible, sir?
Yes, sir.
May I start, sir?
Yes, I think we can start.
Okay. Thank you, sir. Good evening, one and all. So let us begin our today's discussion with a brief history of the patient. So we have a 55-year female who was diagnosed with IgA nephropathy in 2017. Over the next 5 years, she had progressed to CKD stage 5, requiring dialysis. Just a minute. Okay. So we have a 50-year female who was diagnosed with IgA nephropathy in 2017. Over the next 6 years, she progressed to CKD stage 5, needing dialysis. And when patient presented for the first time to IKDRC, she was already in stage 5 and dialysis was initiated. Patient wanted to undergo a renal transplant with husband as the only available donor. And the blood group of the patient was B positive, while that of the donor, husband, was AB positive. So it was basically an AB to B transplant and ABO incompatible transplant if husband was going to be the donor. Regarding her sensitization history, she was a mother to 5 children and had received 1 unit of packed RBCs 3 years ago. So pregnancy was a significant sensitizing event. Now, apart from the routine medical and the surgical evaluation, the immunological evaluation revealed an NTA titer of 1:64, which was fairly okay. And subsequently, single antigen bead screening test was done, which was found to be positive. Now, single antigen bead screen is done at IKDRC for all the transplants, whether it is living donor or a deceased donor transplant. And if the screening test is found to be positive, they subsequently undergo a single antigen bead assay because it enables us to know the strength of the antibodies due to the semi-quantitative nature of the test. So subsequently, single antigen bead assay was done. And third was a cross-match study, which showed that the CDC cross-match was negative, but the flow cross-match turned out to be positive for both B and the T cells. Now here we have the single antigen bead assay of 2023 when she came for the first time for the class 1 HLA genes, and we have the donors HLA. And as we can see that the patient is highly sensitized for the A2 alleles. The MFI is more than 12,000. This is the single antigen bead assay for class 2 HLA genes, and we see that there is no donor-specific antibody over here. This is the HLA of the patient and the donor. Except for the B35 serotype, it is a complete mismatch. So the patient had a HLA mismatch score of 9/10. So we have a 55-year female with a native kidney disease of IgA nephropathy, currently on maintenance hemodialysis. Husband as a potential donor, and if his husband is going to be a donor, it is going to be an AB to B ABO incompatible transplant. Patient having a significant sensitization history with 5 pregnancies with an NTA titer of 1:64. the donor-specific antibody to A2 allele is quite high at more than 12,000 MFI and a positive flow cross-match for both B and the T cells. So the question is, what do we do next? So at this point, three possible options are present. One is we proceed with the desensitization with husband as the donor. Second is we enroll the patient for a paired kidney donation. And third is we can enroll the patient for a deceased donor transplant. Now, if we want to go with a living transplant and we don't want to do a deceased donor transplant, what factors do we consider to decide between ABO incompatible transplant and a paired kidney donation? So first is a blood group. So for any KPD pair, if there is a donor recipient blood group is A and B, it becomes quite easier to find a complementary pair. But if a KPD pair has a O recipient or an AB donor, incompatible ABO transplant would be a better option rather than going for a KPD, unless it is a very high volume center and the available pairs are quite high, large number. Second is the antibody titer. So the institutional practices vary, but at IKDRC, for any anti-A or anti-B titer is more than 1:256, we don't prefer to go for a ABO incompatible transplant and rather they are enrolled for the KPD. Third is the HLA mismatch. So as is already known, greater the HLA mismatch, worse is the long-term graft outcome. So and at a HLA mismatch of more than 5/12 or a 6/12, better to go with a KPD rather than ABO incompatible transplant. Similarly, for a donor relation, if we have a spousal donor, then patient is more likely to have a greater number of HLA mismatch, and so better to go with a KPD if the mismatch is already documented. And finally, we have a donor-specific antibody. So if the patient is highly sensitized, it is always better to go for a KPD. There is no universal cutoff at what MFI level we should reject, but I think everyone will agree that if the MFI is more than 3,000 or there is a positive flow cross-match, then it is better to go with a KPD rather than going with the same donor. So for the current patient, the factors that favored the ABO incompatible transplant was the donor blood group, which was AB, and anti-A titer of 1:64. The factors which favor KPD transplant was a high degree of HLA mismatch, which was 9/10, spousal donor, and a highly sensitized state of the patient with a positive flow cross-match. If we proceed with desensitization with the current donor, then there is a very high immunological risk of a ABO incompatible as well as a HLA incompatible transplant. And therefore, it was considered feasible to proceed for a KPD as well as DDKT. So patient was simultaneously enrolled for both paired kidney donation and a deceased donor transplant. Now, the challenge with the paired kidney donation, as already mentioned, was the blood group of a donor, which was an AB donor, and a highly sensitized state of a recipient, which means that the patient might have to wait for a longer time to get a suitable pair. Similarly, for a deceased donor transplant also, because of a highly sensitized state of the recipient, patient might have to be on a waiting list for a longer time. Now, this is a brief summary of the procedure of a deceased donor transplant at IKDRC. So whenever a potential deceased donor is identified, first HLA of the donor is done, which is followed by generation of the wait list. This wait list generation is done by the computer system itself. This is followed by a virtual cross-match, which is done manually, and a donor-specific antibody of up to 3,000 MFI is considered acceptable. After which 4 potential recipients are called, they undergo flow cross-match, and if that is negative, they undergo renal transplant. Now, generation of the waiting list is done as per the point system. This point system was specified in the GDOT guidelines of 2019, where for different parameters, specific points are assigned, and ultimately the cumulative sum of all the parameters ultimately decides the position of the patient in the waiting list. The sensitized patients receive greater points so that they have a greater priority and they are higher up in the waiting list, as was our current case. If you look at the single antigen bead assay of 2023 for the class 1 HLA alleles, we see that the patient is highly sensitized for both A and the B group of alleles, and the strength of MFI is quite large. Whereas for the class 2 HLA genes, we see that the strength of the MFI is relatively less, and patient seems to be less sensitized for the class 2 HLA alleles. So the two obvious questions arise at this point. One is why patient was predominantly sensitized for the class 1 HLA antigens. The second is, if patient is sensitized to so many alleles, what is the percentage of potential disease donors that the patient is likely to reject? Or conversely, what percentage of disease donors will patient accept? We'll answer both these questions one by one. So first, why patient was predominantly sensitized to the class 1 HLA antigens? So here we have a study done at University of California, where they had analyzed the more than 1,400 pregnant female sera for the amount of sensitization that happened after they conceived. So we see that the patients were predominantly sensitized for the class 1 HLA antigens. We do not see any DR or DQ over here, but it's predominantly either the HLA-B genes or HLA-A genes. One of the first studies in the world that had analyzed the impact of pregnancy on alloimmunization was done by American Society of Histocompatibility and Immunogenetics, where they found that after the very first pregnancy, almost half of the females developed anti-HLA antibodies. And these antibodies were predominantly against the class 1 genes. It was 86% versus class 2, they were only 62%. And they had also found that those females who carried pregnancy till full term had more chances of developing anti-HLA class 1 antibodies as compared to those females who had aborted or who had a premature termination of the pregnancy. Another interesting study from India is a retrospective analysis of more than 1,000 renal transplant recipients, where in this study, they actually wanted to identify the effect of different sensitizing events on the HLA alloimmunization. So what they did is they classified the patients into 4 groups. Group 1 was those who had received blood transfusion. Group 2 was the females who had prior history of pregnancy. Group 3 was those females who had pregnancy as well as blood transfusion received. And the group 4 was those who were retransplant cases. Here we'll be focusing only on the pregnancy and the pregnancy with blood transfusion groups, that is group 2 and 3. And they had used Luminex-based panel reactive antibody to test the alloimmunization status. And what they found was that both these groups, group 2 and 3, females were predominantly sensitized to class 1 HLA genes rather than the class 2 genes. And this box whisker plot also shows that as the number of pregnancies increased, the degree of alloimmunization significantly increases, especially when the female have conceived for more than 3 times. So all these observational studies, they are just like our observation with our current patient. These studies also show that pregnancy predisposes to class 1 HLA antigen sensitization. But what is the probable mechanism? So the exact mechanism is not known, but this study from 2021 tells us that probably that has to do something with the HLA-1B polymorphisms. That is, HLA E, F, and G genes play a role for sensitization to class 1 HLA antigens. What they found is that certain HLA E haplotypes predisposed to increased risk for anti-HLA class 1 immunization, whereas certain HLA haplotypes of HLA-G and HLA-F, they have a more tolerizing effect on the female, and they with these certain haplotypes, the female produce less antibodies to class 1 HLA antigens. So this answers our first question as to why the female was sensitized to more class 1 HLA antigens. To answer the second question as to what percentage of disease donors is the patient likely to reject, or conversely, if the patient has so many different alleles to which she is sensitized, among the available donor pool, what percentage of donors would be acceptable to the patient? So to answer this question, we need to understand the concept of cPRA, or a calculated PRA. And the principle of cPRA is to identify the unacceptable HLA antigens. So for example, if we have a patient who with a single antigen bead assay, and we come to know that the patient is sensitized to, say, 10 HLA class 1 genes, then we can say that those 10 HLA class 1 genes are unacceptable HLA antigens. So this is the first prerequisite, that is identifying the unacceptable HLA antigens. The second thing needed to calculate the cPRA is to know the HLA distribution frequency of a given population, which is representative of a donor population. So for example, Gujarat has a disease donor transplant program ongoing. If you want to find out the cPRA for a given patient in Gujarat, we need to know what is the HLA distribution frequency of a population of Gujarat. It would be like population of Gujarat has the A24 allele seen in, say, 35% of the cases. A11 serotype is seen in, say, 25% of the cases. So once we have these two data of unacceptable HLA antigens and the HLA distribution frequency, we can combine both of them and calculate the cPRA by one of the two methods. One is the allele frequency method, which is used by OPTN in USA for organ allocation, and second is a donor filtering method. Now, along with this, what is important for us is to know the interpretation of the cPRA. So, for example, a patient has a cPRA score of 10. What does it mean? It means that among the 100 potential disease donors, 10 of them would not be acceptable to the patient, and 90 of the potential donors would be acceptable to the patient. Similarly, if we have a cPRA score of 98, it means that the patient has the antibodies produced to the HLA antigens which are common in 98% of the potential donors, and therefore only 2% of the donors are available for the patient. So higher the cPRA score, more sensitized the patient is. Now, we do not have any formal data on India for a region-wise or a state-wise HLA frequency, but based on the disease donor transplants at IKDRC over the last 3 years, and after analyzing the data of 300 disease donors, we have a certain allele distribution frequency obtained. And if we plot these unacceptable antigens for our current patient, we get the HLA distribution frequency as follows. So what we see is that A02, A11, and A24 are amongst the most common alleles found in the Gujarat population, which is in the range of 30 to 35%. So nearly 1 in 3 patients will have one of these alleles. So once we have the data on unacceptable HLA antigens and the HLA distribution frequency, When we use this mathematical formula, we get the cPRA of a 59.5, so roughly 60%. And when the patient had a PRA test done way back in 2023, it showed that the PRA for class 1 was 64%, whereas it was negative for class 2. So here we see that the cPRA and PRA values fairly correlated with each other. And we also see that the cPRA combines both class 1 and class 2. It does not differentiate between the two. So now the next question is, why cPRA scores over PRA? Why is it that cPRA is more important than PRA? So to answer this, there was a study in 2010 which was done in United States, and here they have correlated the value of PRA and the cPRA. So what we find here is, all those patients in whom the PRA was more than 80%, the cPRA correlated fairly well, so that 90% of those cases also had cPRA value of more than 80%. So concordance of PRA with cPRA in a group with a PRA more than 80% was quite high. Now, if we compare those patients with a PRA of 21 to 80%, we see that the cPRA in nearly 20% of the patients was more than 80%, which means that these patients would receive an additional points for their increased sensitization status. And for those patients in whom the PRA was less than 20%, concordance was seen in only 50% of the cases, which means that 50% of the cases with a PRA less than 20 would have a cPRA more than 50, which means that they would also receive additional points, and therefore they would be higher up in the waiting list. The outcome of this was that in 2009, the cPRA based allocation was adopted in the United States for the deceased donor organ allocation, and they found that by adopting these cPRA values, the number of percentage of transplant recipients who were broadly sensitized, they could receive transplant, and the number of these patients nearly doubled from 7% in 2001 to nearly 16% in 2009. And this shows that the cPRA scores over PRA as far as organ allocation is concerned. So coming back to a present case, here we have a patient who is highly sensitized, and patient is already on a waiting list since last 2 years. She was repeatedly rejected due to a positive virtual crossmatch, and hence a decision of desensitization was undertaken. Patient underwent the first cycle of desensitization in October 2024 by Cedars-Sinai protocol, where she received 2 doses of rituximab 500 mg 2 weeks apart, followed by IVIG 2 gram per kg 2 doses 2 weeks apart. And a repeat single antigen bead assay was done after 4 months in February 2025. Here we have the report of single antigen bead assay for class 1 alleles in February 2025. Again, we see that it seems as if the desensitization process has not worked, and the patient continues to be highly sensitized for all those potential alleles. And hence, after waiting for 5 months after the first desensitization cycle, in March 2025, patient again underwent second cycle of desensitization, this time with the plasma exchange. She underwent 5 sessions of plasma exchange along with IVIG with a cumulative dose of 2 gram per kg. And within 2 weeks, so after 15 days of the last session of plasma exchange, patient received a call for a deceased donor transplant. But the catch here is that this patient was called based on the virtual crossmatch on the single antigen bead assay, which was of February 2025. That is pre-plasma exchange. Single antigen bead assay was available. Post-plasma exchange, single antigen bead assay was not yet sent. So patient was fortunate enough to have a negative virtual crossmatch. This is the donor's HLA, and here we have the patient's HLA. So here we see that except for the DQ-B1302, patient has a 7/8 HLA mismatch. So this is the donor's HLA. And here we can see that the February 2025 single antigen bead assay report shows that there is no donor-specific antibody. Fortunately, even the flow crossmatch turned out to be negative, and patient ultimately received the renal transplant on 3rd of April 2025. But the question here is this. We see that the donor's HLA is, or the A locus is A101, and the patient is highly sensitized for the A11 serotype, where the strength of MFI is quite high, it is more than 10,000 MFI. So question is it important to note this observation? Is there any correlation between the A101 and the A11? And the second question is, did plasma exchange really help, or patient received transplant just by chance? So to answer those questions, let's first understand how the antibodies are produced against the HLA epitopes. So here we have the structure of a class 1 HLA molecule. We know that class 1 HLA molecule has alpha 1, alpha 2, and alpha 3 as the polymorphic regions, and the beta 2 microglobulin is a fixed region. And there are certain stretch of amino acids which are fixed, which are specific for different HLA molecules. They're known as private epitopes, and they're shown by a star over here. And certain stretch of amino acids are shared among multiple different HLA molecules, shown by a triangle and a circle over here. So if an antibody is produced against one of these public epitope, then that, for example, an antibody is produced against an A2 molecule, because that stretch of amino acid is also shared among other HLA molecules, the antibody will also cross-react with the other molecules. And this is what we call as a cross-reactive epitope groups. So till now, we have nearly 60 cross-reactive epitope groups identified. This is the list of the CREGs. Now, if you look at our patient's single antigen bead as of February 2025, that is pre-plasma exchange, we see that patient is highly sensitized for the A11 serogroup. Now, this A11 comes under the category of a A1 CREG. A1 CREG includes A11, A3, A29, A30, but patient seems to be sensitized only to the A11 and does not form antibody to the A3, A29, A30. So probably there is a partial cross-matching of a A1 group to A11. So there is a partial A1 CREG pattern seen. And then we also see that multiple antibodies are produced to the A2 locus, A68, A69, and A24. And all of these form a A2 CREG pattern. Now, coming back to the present case, the donor's HLA was A101. The patient is forming antibody against A11. And now we have known that this forms a partial A1 CREG pattern. And therefore, identifying this was important. But the next question is, if the antibody strength is so high, it is in the orders of 10,000, 11,000 MFI, why the flow cross match turned out to be negative? So to answer that, let's look at the single antigen bead assay, which was done post-transplant. And this report is the representative of a post-plasma exchange single antigen report. And if we compare this report with that available pre-plasma exchange, we come to know that the strength of the MFI for the A11 allele has significantly reduced in the order of about 40 to 50%. And probably this was the reason that the flow cross-match turned out to be negative. But again, this is an open question. The strength of MFI is still 6,400, and ideally the flow cross-match should ideally have turned out to be positive. So whether plasma exchange really helped or not remains open. I think probably it did help. And now finally, the post-transplant course. So patient had received a rapid antithymocyte globulin induction at 3 mg per kg, which was divided over 2 days. Patient had a delayed graft function, and she required 4 sessions of hemodialysis in the first 10 days. Allograft biopsy was done on postoperative day 7, which revealed a grade 1B acute T-cell mediated rejection, for which patient received additional 3 doses of methylprednisolone to a cumulative dose of 1.5 gram over 3 days. And as of postoperative day 22, the patient has a serum creatinine of 4.97 mg per deciliter. The graph here shows the trends of the serum creatinine and the urine output in the subsequent days after transplant. We see that the peak creatinine level was seen on POD 16, after which there has been a persistent decline in the creatinine levels, whereas there has been a persistent increase in the urine output from post-op day 10. And the patient is clinically behaving like a polyuric phase of a recovering acute tubular injury. The cold ischemia time in the present case was about 16 to 17 hours, which might have contributed to an acute tubular injury. So to conclude, pregnancy is an important contributor to sensitization, especially for the class 1 HLA antigens, and this risk increases significantly when the number of pregnancies are more than 3. Identifying and doing the organ allocation based on the cPRA is today the need of the hour, and for which the HLA distribution frequency has to be computed for the Indian population. It could be done nationally or region-wise. And regarding the cross-reactive epitope groups, it is good to know the concept of cross-reactive epitope groups, but what is its clinical relevance and what importance does it hold as far as the organ allocation or virtual cross-match is concerned remains an open topic, because if a patient does not have a donor-specific antibody based on virtual cross-match but has a positive CREG pattern, can we simply avoid calling the patient, or we should call the patient and have a flow cross-match done? So I think avoiding calling the patient only on the basis of CREG would be harmful to the patient. Rather, patient should be called and should have a flow cross-match done before deciding whether or not to proceed for a transplant. Thank you.
So thank you, Dr. Shivam, for that extensive presentation. You have covered a lot of area in transplant immunology. So I think it will be easier for the attendees to go through the questions, like whatever questions we have. So Pratik sir, do you have any comment to make or any questions that you have?
No, it's an excellent presentation and excellent way of presenting such a sensitized case. But I think all the attendees may not be that expert in the immunology. So 2-3 things I need to discuss. Number one is regarding these sensitizing events. There's a common sensitizing events like a pregnancy is a blood transfusion or blood product transfusions and a retransplantations as well as current infection. They have a different kind of and anti-HL antibody production few. As he has rightly mentioned, in pregnancy, it is most of class 1. It is most against A or the B, and they're quite unstable and they do not persist. They're not very strong and potent antibodies before transplantations. If you compare it with the other subgroups, suppose the children, pediatric age group, and they having a reflux disease and they develop an antibody that is mostly of a second class 2 antigen and DQ, and they're quite strong and they're very difficult to remove, and chances of rejections in the post-transplantation period is very high. But in cases, so also in the blood transfusion, in the blood product transfusions, it has a different kinds of antibody production potential. Suppose a WBC is a lymphocyte is a transfused, there's a maximum chance of developing the antibodies, and that can be both class 1 and class 2. Followed by there is the RBCs, platelets, and the plasma. Plasma has a significant potential for producing antibodies. But over and above, if you get the most of the sensitized patients are the retransplant patients, other solid organ transplantation, maybe kidney, maybe other solid organ. Those situations we may get a 3 type, both the class 1 and the class 2. Both the condition antibodies are very high. So depending upon the sensitizing events, the antibody production, nature of the antibody production is different. For solid organ retransplantation is both class 1 and class 2, and they're very strong antibodies, and they are present almost in the most of the data. So in 80% cases, these are the causes of sensitization. Secondly, it is closely followed by these infections in the children, and that is class 2 DQ, and that is a strong one, followed by blood transfusion, and probably pregnancy is the least. Because as you see, all the papers you have mentioned, it is quite old, and this has not been much reproduced in the subsequent papers. Whether the multiple pregnancies are really factors for sensitization or not, that has not much paper in the recent times. This is the part 1. And the second one is regarding this PRA versus cPRA. I also agree there is a strong need to make a HLA database, because otherwise you cannot give a cPRA. Because if you don't have our own data, just because of the software provided by the bead companies, we cannot give a cPRA. And that we can do a multi-center studies all over the country. And we have also a data of almost 10,000 patients. So we can also do that. And depending upon the cPRA is the most important thing to assess the level of sensitization of the patient. Here, one point I also like to mention, that declaring an antigen as an unacceptable antigen, only this is not cPRA is required. Sometimes this depends on the practice of the institute. If you get a DSA of the patient, of expecting transplant recipient, and you get an DSA done and MFI is very high, and if your institutional cutoff may be of 5,000 or 10,000, if any antibodies, if the patient is having any antibody which is more than 10,000, like in our hospital, which is more than 10,000, we can declare it as an unacceptable antigen. Without cPRA, you can do that, because these things more than 10,000 or 5,000, we will not accept this antigen. So if the system is there, organ will not be allocated, will be allocated accordingly. And lastly, in the third one, regarding this epitope sharing, I think this is very interesting and very promising, because this you need to know that the whole HLA system is not important. Just small epitopes, those are important, and those are being shared by so many antigens. And if we get a data of ourselves, then we can also other than single antigen bead, we can use a multi-antigen bead, and we can reduce the cost of the testing also as a bead assays. So by that, we can select the patients, invite the patients in a different way by doing a small screening test. Because the PRA testing presently we are doing is not very scientifically acceptable, because that cannot give you the data of the hours. So these 3 points I need to mention regarding one regarding the sensitization, second is regarding cPRA and disclosing an unacceptable antigens. And this is and in the CEDAR-Sinai protocol, you have told that is important. They also practice another thing is a relative intensity scoring. This is basically they accept this DSA at the same time flow cross-match MCS values at the same time as a relative intensity scoring, depending upon how much they have scored. Less than 17 is a lesser chance of developing the rejection, and more than 70 is a more. They don't accept. And in the desensitization protocol, as I just worried, you have told that you have given 2 doses of 2 gram per kg of IVIs. So this is quite high, quite expensive. So can we do in our setup some trials that because in ABO incompatible cases specifically, we have stopped giving IVIG totally. And in the HLA also system, we are also giving lesser doses. So because suppose 60 kg person, he will need out 120 grams in a sitting, another 120 grams in a sitting, means 240 grams is too costly and too higher dose given in a single infusion. So either we can give in multiple infusions and relatively smaller dosage or not. This is another thing I like to mention. Otherwise, it is in very excellent cases, and this is a Craig analysis. This is a very important because it needs some different kinds of statistical method to analyze this. We can get the Spearman P testing, that is analoging method. Means if you want one antigen, your public antigen one by one you are added and it is increasing in number, then only you can do this kind of testing and you can get a more and more epitope suppose in A2 group you may get a 5, after some time you may get 10, after some time you may get a 13, 14, etc. So otherwise it is an excellent case and it was a nicely worked given by Shivam.
Then again, Dr. Arpita, do you have some comments? Are you there, ma'am?
Yes. Hello, everyone. This is an excellent presentation by Dr. Shivam. And I would like to add some points from the laboratory point of view. Because he presented that there was a discordance between the SAB test result and the flow cross-match result. So I would like to add that the lab should check the prozone effect, also the heat inactivation. Prozone effect with a diluted sera to eliminate the high titer antibody, and also the heat inactivation of the sera to eliminate the presence of IgM antibodies. So these two should be in regular practice for every laboratory, whether it is SAB or whether it is flow cross match, for to obtain more accurate result and concordant result. And as Dr. Das said, that we do not know the vaccination, the other infection status of the person, of the patient, and she's a multiparous woman, so it's very obvious that there will be like her immune system is affected by the semi-allogenic fetus. So it's very obvious that she will be highly sensitized with a lot of class 1 antigen positivity. So from laboratory point of view, I think that I should add these 2 points. Lab should check the prozone effect as well as the heat inactivation for the elimination of high titer antibodies as well as the IgM antibodies to get the concordance result between both the assays. So this is a small technical point I would like to add.
Okay, so ma'am, I have a query in my mind. You see, there are so many single antigens being done in such particular patients where, say, the patient is waiting for their deceased donor transplant, or maybe desensitization is happening, or something of those. So, I mean, when you are issuing a report in these settings, or if you are made aware by the clinician, so do you actually go back to all the reports and check, or maybe issue the report as a single continuous report of all the dates? Like, I don't think that is the practice in general, but do you think that would be helpful for the clinician?
Yes, absolutely. It is absolutely necessary for all laboratories as well as clinicians as well as patient part to keep all the records starting from the beginning. Because as per the guideline also, national international guideline also, we should keep a close eye onto the status of the patient's antibody status, because it's vital, because it will help to search out donors, appropriate donors, and also for the management of risk management for the highly sensitized patients. So it's absolutely necessary to keep all the records.
Okay. And do you see a lot of batch to batch, or like in between vendors some variation? Because we have seen that even with plasmapheresis, the initial rituximab and IVIG, the MFIs does not go down very well. Although it's a semi-quantitative thing and we should not be like too much fixated with the numbers, but overall we saw that it did not go down very well. So do you see a lot of batch to batch variation in your lab?
There there could be some batch to batch variation. Even if we are going for the same company kit, like Immucore kit or one lambda kit, but it should be, it is the routine practice for every laboratory which are NABL accredited, whether it is NABL accredited or IFI accredited or ASHI accredited. So they do document lot to lot verification. Lot to lot verification document should be there with the lab, because not for the audit purpose, but for the accuracy of the clinical like reports. So we do take known positive samples, known negative samples, positive control and negative control, and we run it in a same assay setup simultaneously with both the old lot reagent and the new lot reagent. And we just compare that whether there is a fluctuations of MFI. If the fluctuation happens, whether we should like recalculate, putting the threshold, putting the cutoff values can be like we can adjust the cutoff values, or we have to recalculate the positive beat reactive the threshold beat reactive threshold. So it's a routine common practice for all the lab, that lot to lot verification. This is a lab part, and from the company part, there can be some variations like company to company, because there are like beat characteristics difference, and also the assay design difference, on interpretation guideline differences are there from company to company. So there can be some variations, a little variation from company to company, but there should not be like huge variation in terms of results. So it should be there should be parity between the two results. So lab has their own part, and the company, if we go for, so I would prefer that if we are doing test with Immucore, then we have to stick with Immucore for a prolonged time. If we are doing one lambda kit, then we have to stick for one lambda kit for a prolonged time. So we should not mess with the law, with the company.
Right. Okay. And Dr. Shivam, for a last one little point, can I go back to slide 4? Can I go up, please?
Yes, sir.
Yeah, please do that.
Yes, sir.
Okay. Yeah. See, like this is a very important point that I wanted to make. In our setup, what we are having is we are having the the serological equivalents. You can see in the right column we have A2 serology, and we also have the allelic variants, the like A201, A202, A203. So I have seen some of the labs who are issuing a report without this kind of detailing. So like like we'll see in the next case, the report is not like that. So in this case, if you see the from the allelic point, it is like 206 A0206, and that is not present in the allelic distribution. So by mistake, somebody can think that it is not a DSA and may overlook this. Although the flow cross match in this setting was positive, and they might get confused. So I think it is quite important to understand that not all alleles are like very important. And when you are faced with a missing bead, like here 0206 bead is missing from the kit, so you have to go back to serology and understand what exactly is the bead and why is the cross match positive. So that is an important take. So some of the labs, I think all the nephrologists or all the clinicians, they can actually go back and communicate with the lab so that you can have this kind of data. So Dr. Shivam, thank you. Maybe you can stop sharing. We are already running quite late.
Yes.
And I'll invite Dr. Amarnath Jha to present his case. And Dr. Pratik Das sir is also the clinical team member and also the expert for the case.
Hello, good evening, sir.
Yeah, good evening. Good evening.
Sir, am I audible?
Yes, very clearly.
Yes.
Welcome.
Yes. Sir, slides are visible.
Yes, yes, they are. You can go to slide presentations. Yeah, correct. Okay.
Yes, sir. Sir, can I start?
Yes, please.
Yeah. Okay, good evening, everyone. Today I'm going to have a case-based discussion on transplant immunology. So the first slide of my presentation, this is an image taken. There is a program developed at the Cedar Sinai Hospital to treat the highly sensitized patient awaiting the renal transplantation. This was founded by the Dr. Stanley Jordan. And there is we can see there is an image of an antibody model, and there are image of a logo of transplant immunotherapy program, which clearly depicts the mutual interaction between the clinician and immunologist and the helping hand to treat and to help support the patients. So to begin with, my case was a 29-year young gentleman who diagnosed to have end-stage renal disease for came for kidney transplantation. He was detected to have IgA nephropathy biopsy proven in 2018, and since then he was initiated on maintenance hemodialysis for the last 1 year. His father was willing to donate, 58-year-old, and no comorbidities, and with similar blood group. So during the transplant workup, we did the initially antibody screening by the PRA method. Both class 1 and class 2 was negative, and also the cross match was done, which was also negative, and then we did the renal transplantation. So this transplantation was done on 19th June 2020. 2019, and then induction agent was the ATG thymoglobin with methylprednisolone. So patient was discharged with standard triple immunosuppressants with tacrolimus, mycophenolate, mofetil, and steroid, with good urine output and normal serum creatinine on discharge. And he was regularly follow up till 2019 20. Then the period of COVID came. The patient was lost to follow up for some time. The first, when he presented, there was some rise in serum creatine level. Also, along with that, the proteinuria was there. So it may be because of COVID or in irregular follow-up. Then maybe because of the inappropriate dosing and timing of the immunosuppressants, or maybe because of the drug non-compliance, or maybe because of non-availability of the immunosuppression during that COVID time. So this is a graphical representation of the serum creatinine level. And we can see that initially 1 year he was with a good creatine level. And then after there is a gap of 6 to 7 months, at that time, the patient, when after that the patient came, he was having the serum creatine was 1.62, which on repeat test found to still elevated of 1.8. Now the evaluation of the creeping creatine level, we did initially with the USG graph Doppler, which was normal. Then we did the macronuclear stuff level test, which was bit lower level, and the infection and the BKV infection was also ruled out. Then we did the graft biopsies. We can see that there was the evidence of tubulitis, peritubal capillaritis, arteritis, and then the graft, the C4D was also positive, which was suggestive of the mixed rejection, active antibody rejection, and T cell mediated rejection. So the treatment we initiated with the methyl prednisolone pulse dose of 500 milligram over 3 days. Then we gave the 5 sessions of therapeutic plasma exchange with 50 gram of IVIG on alternate days. And then the injection thymoglobin was given 100 milligram over 3 days. Then ultimately the baseline immunosuppression was escalated, and patient somewhat shows some partial response. So over the following 9 months, with these treatments, he showed some slight improvement of the graft function, but this improvement came at the cost of multiple episodes of infection in the form of oropharyngeal candidiasis, pneumonia, and 1 to 2 episodes of UTI, which was treated in the OPD basis. Gradually, over the next 6 months, he's by the end of the August 2022, his serum creatine rose up to 6.5 with speedily edema and uremic symptoms. Then he was counseled and managed as a case of failing graft. Anti-proliferative medications were stopped. Tacrolimus dose was reduced, and he was initiated on maintenance hemodialysis by the end of 2022. Then, after 6 months, the patient again had an episode of recurrent pyelonephritis in the form of fever, pain, tenderness at the graft site with overt hematuria. Then we did the contrast enhanced CT of the kidney. We showed the grossly edematous kidney with features of inflammation, fat standing, which is suggestive of graft pyelonephritis. He was initially managed with broad spectrum IV antibiotics and but did not show a good adequate response. So ultimately, the graft nephrectomy was done, and he was kept on maintenance hemodialysis, and immunosuppressions were withdrawn. This the gross appearance of this kidney was swollen graft kidney, motile appearance, and thrombus renal artery and vein. The histopathology examination showed marked IFTA with features of pyelonephritis. Now here comes the this is the patient that graft nephrectomy is not a dead road end. So the all the options and the counseling was with medical management was explained to the patient. He was kept on maintenance hemodialysis, and the option of retransplant, which is the best mode of renal replacement therapy, was explained and started. So there was a new hope. The patient was, which was initially not a sensitized patient, now become sensitized, maybe because of history of transplantation, or maybe because of withdrawal of immunosuppression, or maybe because of transfusion of PRBC during the surgery. So this sensitized was evident in this report that we did the repeat PRA test last year, so which was showing the both class 1 and class 2 was positive. This was the initial SAB test which we do here, which showing high uh, antibody titers. So for the transplantation workup, the first donor was aunt, same blood group, but initial workup, the cross match was significantly positive. So we advised to change the donor. Then the elder sister came for the donation, willing for donate, but the cross match was still strong positive. Then we had counsel for the change the donor, and finally he was also enlisted in the disease cadaveric transplant. And in the meantime, the mother, his mother was willing to donate. She was 49 years old. Haplo match was there, but different blood group, which was evident in that baseline NTB titer was 1:32. And fortunately, the cross match was with mother was negative. So the next option was to desensitize and repeat the cross match and work up for the transplant, and to think of another new donor with without any unacceptable antigen, and to work for the kidney pair donor exchange. So the last option we don't carry much in our setup, and working for the new donor is very cumbersome. Uh, and so we carried out to desensitize the patient and to repeat for the cross match. During the further transplant workup, we did the, this was the SAB report as we have already seen. Now to see the donor specific antibody, we match with the HLA report of the donor, that is the mother. Then we found that the DRB1 was significantly high, levels of 7,600, and the DQB1 was approximately more than 10,000. So what is the ideal target? So there should not be any unacceptable antigen. As sir has already discussed, in our setup, we don't take patients with unacceptable antigen of MFI level more than 10,000. And we calculated the relative intensity score. In our patient, we found to be 15, and which is ideally should be less than 17. If the RIS score is more than 17, then patient should not be taken for transplant, as there is high risk of rejection. And the flow cytometry T cell median channel shift MCS should be less than 150. So we continued, and we carried out the desensitization for combined ABO and HLA incompatible transplantation. Initially, we gave the rituximab dose in our setup. In this patient, we gave 500 milligram, and still the dose is not standardized in the whole world. Rituximab just depletes the B cells, and then we carry out for the antibody removal by the therapeutic plasma exchange on alternate day. The replacement fluid we gave with albumin and donor plasma, and the dose of IVIG is still, as sir told in the lower form, that after each plasma we give 10 gram alternate days. So this is our protocol. Initially, we gave the rituximab of 500 milligram. Then we carried out the plasmapheresis and IVIG. in the lower form, 10 gram on alternate day. Then we repeat the before transplant, we repeat the cross match. We accept usually with anti-A or B titer with less than 1:32. And at the end, in before the surgery, we give methylprednisolone and the thymoglobulin in sensitized patients, and baseline immunosuppressants was carried out. So before the transplant surgery, so this was the flow cross match report showing the B cell negative, and the CDC cross match was also done before the surgery, and the baseline and the before final titer, final anti-B antibody titer was 2 before surgery. So for just then subsequently we did the second renal transplant surgery on 20 November 2024. It was left iliac fossa. Induction agent was ATG in the form 3 milligram per kg. Donor, as we discussed, mother 49 years old. The surgery was uneventful, discharged with good urine output, and the serum creatinine was very good during the discharge. So to summarize, this is the brief timeline. In 2018, he was diagnosed to have IgA nephropathy. Then in the 2019, the renal transplant was done. In the subsequent years, he had mixed rejection. Then he was treated, showing partial response. Then he developed repeated infections and graft started on maintenance hemodialysis by the end of 2022. And in the March of 2023, because of recurrent pyelonephritis, he had graft nephrectomy and carried out the second transplant for the desensitization in 2024, and the second transplant was done in this. So during the follow-up, this time he was on regular follow-up, one stable graft function, but still this time he was having 2 episodes of UTI, which was managed with oral antibiotics on the OPD basis. So now the issues. Now we will discuss the issues. So I would like Pratik sir to carry on.
No, basically the idea of presenting the case that we all encounter with these patients who are sensitized patients. Sensitization may be due to, mostly we get the cases that due to retransplantation. As I have already discussed, as a retransplant, there's several reasons that retransplant patients are immunogenic or maybe sensitized, that may be related to the rejection, particularly those patients who develop a rejection in first 2 years of the transplantations and lose the graft in first 2 years time. They are more chance of sensitization. And at the same time, there is another, if there is not much hope for these retransplantations, immunosuppression withdrawal is another thing that may precipitate this HLA sensitization. And thirdly, many of the cases like this one, they require a graft nephrectomy, and after that we stop these immunosuppression. So now basically the in the last cases we are discussing whether plasmapheresis worked or not merely removing the antibody is not enough. It may be the memory. So by completely withdrawing the immunosuppression may have an additional role in producing the sensitized patient after transplantation. So the retransplantation cases may be class 1, maybe class 2. As you can see in these cases, it is mostly both in the class 1 and the class 2. But desensitization protocol, I have a few points to mention that if you get an ABO at the same time HLA sensitized patients, as the HLA sensitized patients require more intense desensitization that almost practically covers everything. Slightly differences is like that rituximab dose we use in ABO cases only 100 to 200 milligram, but here we use the 500 milligram, not 2 doses, only single doses. We don't prescribe normally in the ABO incompatible cases in IVIG, only in the just replacement only 500 milligram. But here we use 1 milligram per kg body weight. We couldn't do 2 milligram because most of the patients cannot afford. In the plasmapheresis, one important thing that here the titer was 32, but even in a high titer, you cannot use the column, because the column will remove specific ABO antibody or maybe the HLA antibody. Both column, using both column is hugely expensive. So plasmapheresis is the only way to remove the antibodies. And here is the replacement fluid better should be replaced by the mostly by the albumin, because of this chances of more sensitization by the plasma. At the same time, you need a donor's plasma or the AB group plasma so that it doesn't contain much of the antibodies. And this is that's another important thing, because as most of the institutes in the private institutes, they charge for this SAB testing. So repeating SAB testing time and again to see the MFI count has reduced or not, that may be sometimes expensive. So our practice is that we do the DSA testing, do the desensitization, and after that, if we get a flow negative, at the same time CDC is negative with a median channel shift of less than 150 for the B cells and less than 70 for the T cells, we accept them for the transplantations. But the problem in this patient is that this patient has a significant episodes of infection in the first transplantation. The graft was removed because of the huge pyelonephritis, and so in any sensitized patient, the story doesn't end with the transplantation. You can put it in the disease donation, you can put him in the paired donation program, you can take him for the desensitization, after that the retransplantation or the transplantation. But the problem remains that after a few window period, the antibody comes back and the chances of rejection is much more higher. In all studies, antibody-mediated rejection, it is in the first 3 months of time, it is very high. If it goes beyond that, then gradually, it is unlike that of IPO incompatible, where the chances of rejection is much less because of the accommodation beyond 1 month of the time. But if you, in those cases, if you want to monitor the monitoring of such patient in the post-transplantation period is important. In the TTS guideline, mostly the patient who haven't preformed HL antibodies, they asked to monitor every month these DSA values. And if the DSA values goes on rising or a new DSA appears, in those cases they ask for a biopsy. If the biopsy says a rejection, in those cases you have to treat them. But in those cases, doing DSA repeated times, I've already told it may be difficult. So ideal way of post-transplant monitoring is important in terms of immunology is doing either a protocol biopsy in a certain period of time, or we are nowadays doing it with a cell-free DNA with lots of after the transplantation surgery period is over beyond 1 month time with lots of disadvantages, but still it gives you a clue if you do it in the numbers. So this gives the immunological status. At the same time, we are very much afraid of reducing the immunosuppression in these patients because of thinking that the rejection may precipitate at any point of time. That incurs more infections, maybe a pneumonia, maybe an UTI, maybe a BK virus, anything. So the balancing is very important in the post-transplant monitoring. At one point, you have to look for the patient is over immunosuppressed and more chances of infection, or under immunosuppressed and is more chances of rejection. So in the next few slides, Amarnath will tell how do we monitor in the post-transplantation period in any patient who is sensitized and underwent a transplantation, be it a deceased donor, be it a paired donation, and be it a desensitization. Yes, Amarnath, please.
Yes. So just like sir told, so there should be an adequate balance between a balance of immunosuppression to prevent the rejection and prevent the patient from infection also. So at this moment, in a sensitized patient, how to titrate the immunosuppressants? So there is a need of the immunometer. So which will tell how the patient is the risk of immunosuppression or the risk of infection or in rejection. So there are multiple tests and multiple markers have been came in the market that like blood transcripts, ELISpot, urinary chemokines, cell-free DNA. But these reports, these tests, these investigations still require more validation. So the current concept is the load of the TTV virus or virus, which can tell that there is high risk of infection if the load of if there is high TTV load, indicating there is high immunosuppression. So we can use it as a meter of we can use it as a immunometer. So in our patient, initially we did the donor-derived cell-free DNA, which was normal. So then we did this virus quantification assay. This is done by the serum PCR. So this showing the level of approximately 9 log copies per ml. So this means that the patient was slightly over immunosuppressed just like he was having repeated infections. So just go briefly about the virus. It is a small single-stranded DNA virus which belongs to the member of Annuliviridae family that infect almost everyone without causing any documented disease. It was first described in 1997. This virus is highly prevalent, can be found in 90% of the healthy individuals, and it can be found up to 100% in solid organ transplant patients. Fernandez and Rui et al., they have found a high TTV load to be predictive of BKV virus infection that develops over the 2 months post-transplant period. this TTV virus is detected by the means of quantitative PCR test. And since 2021, a commercial in vitro diagnostic regulatory confirmed assay is available for the clinical use. Lot of studies are there. This image is the correlation of the TTV copies per milliliter in the immediate post-transplant period. There was a study which showed that the TTV virus load could serve as a predictor of allograft rejection, but not of infection. There is a good article which was published in the Transplantation Society, which showed that there is an association of TTV virus and the subclinical graft rejection in kidney transplant patients, and the viral load of less than 10 to the power 6 copies per milliliter. They suggest that suboptimal immunosuppression is there. There was another study which showed that in ABO incompatible patients, they are higher risk of developing BK virus nephropathy and higher TTV load and immunosuppressive burden. They suggest that the intense immunosuppression rather than intrinsic attribute conferred by this transplant may contribute to this finding. So, to conclude, there is the main target is to achieve between the main target is to achieve the right balance between the immunosuppression to prevent the patient from infection and to rejection. And this, I think this TTV virus load is very helpful in the coming future. Thank you, sir.
Yes. Basically, the idea is that not transplantation in a sensitized patient is doing a transplantation in a sensitized patient is not enough. You have to save the graft. You have to save the patient. Most of the test post-transplant immunomonitoring was targeting towards this under immunosuppression and precipitation of rejection. You may get an ELISpot testing. You may get an urinary granzyme perforins, you can get cell-free DNA, all were targeting to detect in a non-invasive way of diagnosing and rejection in the post-transplant period. Amongst these, probably cell-free DNA in the first 15 or 20 days period, because of the surgery, it may be falsely elevated. You cannot do that. But after that, can be a good marker, and we have done almost in 140 cases in the post-transplantation period, and we got 0.8 or above is a good suggestive. We correlated with the biopsy. So it correlates with the antibody-mediated rejection. It is not a marker of cell-mediated rejection. It is not a marker of even the BK virus or the pyelonephritis, but it is more of antibody-mediated rejection. But it is costly. It is not widely available. Again, with the same problem with these DSA beads, which are not of ours. So secondly, the only thing, whether most of the patients in a country like ours dies due to infection. So whether the patient is very prone to develop infection or not, very few methods has been developed. So that's why this tortinovirus issue has been taken up. It is a very simple way of testing. It costs not more than 2,000 to 3,000 rupees for doing this test. And you can get a result for this, and it is commercially available also in 8,000 to 9,000 rupees. So whenever you think you are planning to reduce your immunosuppression and you are not able to reduce it because of you are thinking the rejection may be precipitated, this can help. In these patients, up to 3 months of time, we didn't at all reduce the immunosuppression. We continued everything. But when the patient started 2 or 3 episodes of infection, then we did this test, and it was very high count. It was more than with the 10 to the power 9 logs like that. And we suggest the patient was over immunosuppressed and reduce the dose subsequently, and patient was stabilized. So this is a two-part. One part nicely discussed by Dr. Shivam, how a pre-transplant sensitized patient can be ideally put up if you have all the evidence, all these paired donation program, disease donor transplantation program, as well as the live and ABO one. So how can we deal that? And in the next case, in the similar cases, we have dealt with how do you monitor in the post-transplant period to give them an infection-free and rejection-free life.
Thanks for that wonderful sum up of the entire thing. So we have a few questions in the question answer box in the chat box. So one is a question directed at the ABO incompatible transplants that you are doing. So what is the plasma that you are using? So you are using donor group plasma or AB
Yes,
negative?
Donor group plasma, sir.
We use donor.
Okay, so why do you make that choice? Like, is it like what drives that choice?
No, this is basically either you can do a donors group plasma or an AB group plasma. The availability of AB group plasma is not that high because all over India, like in the Eastern India, AB blood group is not.
So
So we don't get any, in those cases, suppose a patient, because we replace everything by plasma because it is in the hospital package and this is a less costlier one. And that is not much available. So we use the donors group of plasma most of the time.
okay. And what is your experience with DP antibodies, sir?
DQ.
DP. Do you do DP typing?
DP typing after 2021, we started doing these DP antibodies. And these things, this is very difficult antibody to remove, like that of DQ. Even you do 5, 6, 10 plasma exchange and give a high dose of immunoglobulin, hardly you can reduce the titer by 2000 or 3000. So it is very difficult antibody to remove. But how they affect in the post-transplant period, that we have not studied.
Okay. So by and large, at our center, our practice is to, we kind of neglect up to 10, say around 15 to 20, 15,000 odd, we are able to tolerate. So we don't do DP for everybody. So we are doing DP only for selected patients where the single antigen screen that comes with the DP titers, if that is positive, and living donor setup, we do that. And for a deceased donor setup, we only do retrospectively. So it is not available at the time of the transplant. But by and large, what we have seen is these DP antibodies, they come up only in the post-transplant patients. It usually does not come because of blood transfusions or pregnancies. So I've never seen a DP antibody come up because of pregnancy or anything. It is usually only post-transplant, usually. So, ma'am, Dr. Arpita, ma'am, so if you're there, is your center still doing DP antibodies for everybody? What is your practice, ma'am?
Yes, when I was working in Kolkata, there was a routine practice to type for both, like all the class 2 antibodies like DR, DQ, and DP by Luminex.
Okay.
Yes.
Right. Okay, and one question to Dr. Amar. Like what we have seen is your the cross match. This the CDC cross match and was negative with the mother for the second transplant
Yes, sir.
when you took the mother. So the CDC was negative. What was the result of the flow cross match?
Sir, flow cross match was T cell was negative. Initially, we did not do the flow cross match. Just flow cross match was done before the transplant after desensitization, sir.
Okay, so that is a
And
rather odd choice because we know that if once you give rituximab, flow is the one which goes for a toss. It is very difficult to
yes,
understand, and
just
in the
because
presence of
before that,
a yeah.
yes, sir, before desensitization, we have done the SAB test, as we can evident that how much is the titer, which is more that's why we
Yeah,
have
so
initially not done the flow cross match.
right, and that brings us to a very important point that you may have a negative cross match. So and yet you may have so much high titer antibodies.
Yes,
Like in your case, it was around what 6,000-7,000 if I'm not wrong. So 10,000 and 7,000. So
7,000. Yes,
even
sir.
with it, so CDC is a very poor marker, I guess, because if you had gone ahead with this CDC cross match without doing a single antigen bead, so this person, I think he's aged around 34 years right now. So he has
Yes, sir.
already had a transplant with a father donor. That kidney is already gone. So the options like he's broadly sensitized. So we need the graft to function well. So now that you were able to do a single antigen bead, that gave us this information that yes, he's still sensitized to the mother, and now we need to do something. So the probability of having this actually might have resulted in a very early graft loss, say in a year or two, or even maybe earlier also. I don't expect a
Yes, sir.
hyperacute rejection in this setting because like usually DR and DQ will not cause hyperacute, but this would have caused a tremendous amount of morbidity in the post-transplant.
Yes.
Yes.
So
Right.
that can be done in the post-transplant period. This SAB can be done to assess the
Yeah,
risk.
at least for post-transplant patients or like second transplants, which I think it should become a standard practice to do a single antigen bead test because the average cost of a transplant in the worst settings, like the cheapest setting, would be around say right now I think it will be around say 3 lakhs, 3.5 lakhs, and it just costs around 30,000 to do a single antigen bead assay. So we are and God forbid the patient lands in rejection, the cost goes up by enormously.
No, actually, not scientific, we do this PRA in the whatever the method and acceptability is. We do the PRA in every patient almost in 3 months, 6 months, and 9 months and 12 months time. Somebody gives a 2, this is positive. Suppose the class 2 is positive, then we do the SAB for the class 2 only. If the class 1 is positive, then class 1 only. That gives some cost benefit.
Yes.
This also requires the lab to take lesser charges, and that will be definitely.
Yeah, so cost is an important factor. So any final comments, sir, before we close down the session?
No, it was nice, but that is another thing I convey the message. We need our own HLA bank or our HLA. We need to know the HLA of our population so that we can our own cPRA, because this is very important testing. Everybody have a 5,000, 6,000, including donor and recipient. You can get so many patients HLA. You need a system and put this.
So I have a funny point to make. Like this cPRA was we don't usually do this cPRA thing, but this was a last moment thing when we were starting to do this presentation. So we used ChatGPT to create this program. Dr. Divesh Engineer, he's actually, I mean, very much into all of this. So he just used ChatGPT and created this program just offhand. He did have the data to go with that. So we were able to manage like what exactly is the cPRA. So this happened, I think in December, uh, when he was trying to think like this patient was under his care. So like how we should approach this patient. Should we go for desensitization or not? Because this patient was fully paying out of their own pockets. So the cost was very important. So we did this exercise of finding the PRA, and with the information that around 60% cPRA. So the chances of having, because she was on top of the list, she got I mean, she was shortlisted for at least 5 to 6 times, but every time virtual cross match would be positive. So the chances of her getting a transplant would be very less unless we did something for her. So that was so ChatGPT can help. So any last comments, Harpita ma'am?
No, nothing. And this is indeed a very good idea of like post-transplant, this TTV guided immune suppression. So thank you, Dr. Das, and thank you, Dr. Jha.
Yeah. So do you think it is this now? I mean, it seems to me that it's quite interesting that we are actually having a universal cutoff. Like what they have shown is around 10 to the power 6 to 10 to the power 8, or in your case, I don't know, I don't have the numbers. So do you think it will actually vary from patient to patient as more and more data is there? Because we have seen with the same kind of immunosuppression, some people will land up in the ICU with a bad pneumonia. Some person with the same immunosuppression, very similar tacrolimus levels, and we don't do MMF levels and everything, and they will have a bad rejection, maybe lose their graft. So it's kind of very variable. So I think it is also about how the patient will tolerate. So do you think the patient will be the best reference for himself or herself, or like can we? I mean, do you think a future is there where exactly these standard cutoffs can be used for in general in practice?
The cutoff on the time basis, within the timeline, and how much in the post 1 month, 2 months, 6 months, 1 year, but not patient to patient variation. They have told.
Yes.
One thing
Seems
I just
very...
is this session is not complete until and unless we discuss in future sessions something about imlifidase, because I think it will be a very crucial role in such a highly sensitized patients who are planning for transplantations, and how this changes the transplantation scenario. Your induction plan is changed, your desensitization plan is off, your post-transplant rejection treatment is totally different, but the outcome is much better compared to the present.
Yeah. So we are actually trying to get a few experts who have actually real world expertise with imlifidase. So for the Jaipur ISOT.
Okay.
So which is around the corner. So we are trying to rope in some people. So we are in touch with a few centers who probably will accept, because ISOT is a big platform. So I'm very hopeful that we'll be able to get something of interest for everybody. So with that, I think we can now call the end to this session. Thank you, Dr. Amarnath Jha and Dr. Shivam for your excellent presentations. Pratikda sir for your excellent inputs throughout the course of getting all the cases done. Arpita ma'am for your inputs, and thank you for being present throughout the day, throughout the time. And I'm very sorry to Dr. Kandaswamy who was unable to join because of some technical issue from his center and probably the Zoom links and everything. And to all the attendees, have a very good evening.
And
And
thank you, Dr. Shubho, for this. He is a nice leader.
yeah, no. It's always an interesting thing to do.
Yes.
Thank you, sir. Thank you. Good night.
Thank you, sir.
Thank you, sir. Thank you.